Great. I'm Ann Duggan, and it's my pleasure to introduce today's speaker, Dr. Lauren Supplee, who's going to be speaking about 50 Shades of Evidence in Policy. I've known Lauren since, I think, 2010. We met when Lauren was my project officer for the National Evaluation of Home Visiting that was led by MDRC and in which Hopkins played a role. Lauren got her PhD in educational psychology at Indiana University. She went to University of Pittsburgh and worked there 7 years as a research associate. Then left academia to go to DHHS, to a part of the Administration for Children and Families called OPRE, the Office for, I know this, Planning, Research, and Evaluation. And that's where she was working when I first met her. I didn't know what OPRE was before that. But over those years since then, I became more and more impressed with the importance and the quality of the work they do to assure that the services for families, particularly with children, in the area of early childhood, family support, child abuse and neglect prevention, are top-notch and as impactful as possible. Lauren said usually after 7 years or so, she kind of gets itchy and needs a change. So after she lasted 10 years at OPRE, and then I was about a year and a half ago now.
Almost 2 years in September.
Okay, went to Child Trends, where she has really very rapidly advanced through the ranks to become the Deputy Chief Operating Officer, and she's a Senior Program Area Director for Early Childhood Research. I'll share one little vignette and then I'll relinquish the mic. Those of us who do home visiting research and those of you who hang out with us know that the world changed dramatically in 2010 with the Affordable Care Act when the federal government began a huge investment in the scale-up of evidence-based home visiting. Lauren knows what she's talking about when she talks about evidence, and we're really, really lucky to have her here. As part of the preparation for that investment in evidence-based home visiting, you might think what the question that begs is, well, what is evidence-based home visiting? And among other things, Lauren was the brains behind what's called Home V, which is an ongoing systematic review of the evidence of various models of home visiting using very rigorous standards and then designating models whose evidence meets those standards as evidence-based. There are now, I guess, 20 evidence-based models. I think when you started Home V, how many?
7.
There were 7, but how many different models were in the literature?
Oh, we found over 20,000 citations and 275 potential models.
Okay, and this is, frankly, these models, it's business. So people really, really cared about whether or not they were designated as evidence-based. And Lauren had to develop a system that was efficient and scientifically very, very rigorous and a system people could have faith in. So I'm not going to waste any more time. Let's turn it over to Lauren. Join me in welcoming her.
Thank you, Anne, and thank you so much for having me here. I was mentioning to Cynthia that as I practiced my slides for this talk, I got really excited because in my current role, I don't get to talk about this quite as much as in my previous position, and I love to geek out over evidence-based policy. So hopefully my enthusiasm, I can share it with you, and you can also get excited about this topic. So Anne already went over kind of my career trajectory, so I'm not going to go over it here, but just to say that a lot of what I'm talking about happened in that position at the Administration for Children and Families. So in addition to being heavily involved in the maternal, infant, and early childhood home visiting program, which is one of the tiered evidence programs, in the last 3 years I was at OPRE, I oversaw a division in which there were actually a number of different evidence-based policy initiatives, including teen pregnancy prevention. There was work around fatherhood. And so I was able to sort of see the breadth of evidence-based policy as well as organizing a cross-agency work group of all of the tiered evidence programs. So I'm drawing from all of that experience. So I'm going to focus today on Three main topics. So first is evidence-based policy. I'm very fond of saying it's a lot more complicated than it seems, and hopefully I'll be able to convey that in my talk today. I'm going to go over kind of a broad brush of the history of evidence-based policy, because I find not everybody knows sort of how long it goes back and where a lot of it originated. And then some opportunities and challenges that I see having been involved in it. So as many of you are probably familiar, the idea of evidence-based policy really came out of the idea of evidence-based medicine. And so the idea was that you were getting the input of evidence from rigorous studies, as well as client input, as well as clinical judgment. What we hear often, though, is that the focus is really on the evidence piece, and people kind of miss those other two pieces of the conversation. And what we also hear oftentimes is there's a field of study of the use of research evidence in policy, which is fascinating, and I'm happy to answer questions about it. But they have these typologies of how evidence gets used in policymaking. And what you often hear is people talk about imposed use or instrumental use. So imposed use is basically someone says you must use this evidence-based program in order to get funding. And instrumental use is basically something to be able to point to a piece of policy making or legislation, and it says, because of the research evidence in this field, we are doing X. But I'm here to tell you that is quite rare, and actually there's a lot of other ways that evidence gets used in policy making, and I'll touch on a few of them here and there. But I think I would really like us as a field to think more broadly about what do we mean by the use of evidence in policy making. So I mentioned that what's often missing in this conversation about evidence-based policy making are those other two pillars. So patient input is very much missing, and that could be stakeholder input or whomever is actually going to be experiencing these programs. And I think I recently had a paper I wrote about sort of trying to look at the people who we're trying to bring in, particularly to prevention programs, because that's particularly hard because people haven't yet identified if there is a need, but really working with them, like, why would you want to participate in this program? And what does this mean to you? And what challenges are you facing? And then the second is this clinical judgment. I think we have often left out the implementors or even the state agencies or county-based agencies that are going to be implementing these programs. And what we find is, you know, Anne mentioned I used to oversee this systematic review of home visiting, is that they would contact us and they'd say, yeah, that's great, you looked at the evidence, but what I really want to know is how acceptable is this program going to be to the families in my community? Or how ready are these community-based agencies to implement a program like this? And how externally valid are these results? And to be honest, we don't have that kind of information in the field. They would also ask questions about, like, how much does this cost? How much training? Like, you know, particularly in home visiting, we have lots of turnover. So how much is it going to cost for me to keep retraining staff? All of these kinds of questions we actually don't do a good job of incorporating into conversations around evidence-based policy. But I think when people have brought the idea of evidence-based policy into government, they have ideally I'm going to share with you what the state of Iowa did with their maternal, infant, and early childhood home visiting program. But I will tell you that I have heard this is somewhat rare. So I think this is just a case example. So what they did was they basically took the evidence that we looked at in our systematic review. They then also looked at epidemiological information to look at where are the needs and risks in their communities. And then they went out to all of the counties across the state and they did focus groups with the potential parents and with the potential providers and showed them this data and said, what do you think we should do? And in some counties, they already had home visiting programs, but those home visiting programs, the evidence on them didn't align with what the epidemiological data said is the risk and need in the community. So they had a conversation about what would that mean. And then through that, she was actually able to get some of them to change the model that they were implementing, which I think without this process would probably have been a much harder lift. But that took a lot of time and a lot of effort, which is, I think, one of the reasons why it doesn't always roll out this way. But I think that's what, when you talk to a policymaker, that's kind of what they think is happening. The definition of evidence also varies widely. You know, we can talk about evidence-based policy, but when you start talking in different fields, there's lots of terminology that gets thrown around, that promising approaches, innovative approaches, practice-based evidence. And, you know, when you use the term evidence-based policy, like, what kind of evidence are you including in that? I think from a policy standpoint, at least where we are right now, talking to Hill staff and some of the more the executive branch leadership, they really equated evidence to meet the evidence-based policy as impact trials. Now, you can debate whether you agree with that or not, but that's the threshold. And then obviously there have been many agencies, like CDC has developed sort of a continuum of evidence to say we need to move along the continuum. And we want to actually, we've emphasized this idea of including innovation and testing throughout this continuum, but that the end goal still remains having some kind of impact trial. So I'm going to give you a broad brush of sort of the history of evidence-based policy in the government, and I'll end with the current administration and sort of what at least I've sensed of what's happening. So to start, most people don't realize that a lot of these things actually started in the Bush administration. So these are some examples, and I'll go through each one of them. So the Bush administration started something called the Performance Assessment Rating Tool, or the PART assessment, which was basically asking all federal programs to set performance objectives, and if they can include impact studies in those performance objectives to say, are you meeting the objectives of your mission of your agency? And then they would post these all on a website. And the idea, I think, was a little bit of like public shaming. If you're not meeting these objectives, then what do we do about it? It was definitely seen as sort of punitive. It took a lot of personnel resources to do, and I think people criticized it that oftentimes what was being measured were outputs and not outcomes. How many people did we serve, but not did we actually change the lives of these families. PART has not gone away, it's just kind of morphed over time, but that was really a big push in that administration. The second bullet is the What Works Clearinghouse and the National Registry for Evidence-Based Programs and Practices. So the What Works Clearinghouse is from the Department of Education, and the National Registry was out of the SAMHSA, the Substance Abuse and Mental Health Services Administration within HHS. These were really sort of some of the first big signature movements in the government to do systematic reviews with the idea of sort of, if you build it, they will come. If you put information out on the website and we will show you how evidence-based these various things are, people will change the way they operate. Of course, that didn't happen. And I will say the What Works Clearinghouse was originally named the Nothing Works Clearinghouse because in the field of evidence and education, there were very few impact trials going on. In that same bullet is IES, the Institute for Education Sciences. So this is actually essentially the NIH for the Department of Education. And they saw that there was this Nothing Works Clearinghouse and decided to basically change how much emphasis they had on what they funded in impact trials. And it has transformed the field of education. For better or worse, you can draw your judgment on whether you think that was the right move for this field. But the state of evidence in education is completely different from where it was 10 years ago when the Institute for Education Sciences formed. The last bullet is something that I was personally involved in, which was, there was a small little piece in a budget bill that talked about, we want to test this idea of this nurse home visiting, and it was called the Supporting Evidence-Based Home Visiting Project. Anne was actually one of our local, one of our grantees, and the idea was sort of to test out what would it take at an infrastructure level to actually scale up evidence-based home visiting, and it was a really interesting, pretty innovative way to start pushing towards scaling up. It had a rocky history because as what happens in the middle of an administration is you have new leadership with new priorities, and the new leadership wasn't necessarily on board with everything that the Bush administration started, and we had their funding cut. And year two, it was scrambling. They managed to save the funding, but people forget that that was sort of the first foray into this. The Obama administration, it really has a reputation of being the evidence-based policy administration. And they have this for a number of reasons. I mean, you can see this quote here from his acceptance speech. He immediately started citing science and trying to use science to decide sort of what gets funded. And he was different in that, to moving a little bit away from that punitive to say we're going to use evidence to then improve programs if they're not working, because he recognized that there are some times that you can't just cut the program, right? If you cut Head Start, you still have almost 1 million children who need early care and education. What are you going to do with them? So maybe there should be some program improvement piece. So he emphasized the use of evidence definitely in budget and management decisions. When agencies submitted their budget to say, this is what we're going to do next year, they had to justify what they were doing based on the available evidence. He also was the administration that spearheaded these things called tiered evidence initiatives, which was basically saying, we're going to reserve the vast majority of funds that a state or a county might get for something that is deemed evidence-based, with a smaller pot of money that was sort of for innovative programs which then were rigorously tested. But this was a really different way of doing government work. And what you saw as a consequence of this was a rapid increase in the number of systematic reviews. So I mentioned we had those two big ones in the Bush administration. By the time that I started convening a working group across agencies, we had like 13 systematic reviews. And these were big, mostly high stakes. This is not just sort of, this thing has evidence, but now we're saying in order to get funding, you have to get on this list. So there were millions of dollars sometimes at stake about whether your model was deemed evidence-based or not. The prescriptiveness and flexibility within these tiered evidence initiatives varied, and I'm actually going to show you some examples of some of the statutory language to give you a sense of sort of what I mean by that. But there's lots of different ways that you can embed evidence requirements into these kinds of programs. The Obama administration started something called the Evidence Team. The Office of Management and Budget, if you're not familiar with government, is probably one of the most powerful government offices. They determine what budget agencies get and how they get to spend their money. And whoever controls the purse controls the power, right? And so they had this evidence team that actually went around and basically said to agencies, okay, how are you doing in research? How much research are you doing? How are you using that research? And just them asking questions and knocking on doors got people to pay a lot more attention to the evidence in policymaking. They also emphasized this idea of pay for success or social impact bonds, which is this public-private partnership where a company like a Goldman Sachs steps in and says, I will give Arizona $50 million to scale up an evidence-based program, but you must test whether you're going to achieve the outcomes we think, the social outcomes we think that this program should achieve. And if you don't achieve them, the state has to pay Goldman Sachs back. So it's actually seen, it comes out of the UK, it's seen as this great way to get private dollars into public investments. But it's pretty high stakes, especially given that some of these prevention programs, as we all know, the effect sizes are still pretty small. So I know there's one, what they call them social impact bonds, like contracts, that's hedging their bet on nurse-family partnership in South Carolina, changing preterm birth and NICU stays. There is very little evidence that NFP can actually do that. So I'm worried personally that if they then decide that it doesn't achieve it, then they're going to throw out that evidence-based home visiting can achieve social good. So I think it's a risky idea, but it has certainly taken off. And then finally, the social and behavioral sciences team started in the White House, now moved into an agency to try to embed itself. But it was using, they talk about behavioral economics. To me, as a psychologist, it's basically taking the field of economics realized psychology has something to say about human behavior, and they've taken human behavior and they've stuck it into economics. So that's basically, they went through and started doing little tweaks. So for example, the loan repayment program at the Department of Education for your college loans, they did random assignment where they changed the email that you got to see whether that increased the number of people that made payments on time and didn't go into default. And they found a whopping increase, which is great because these are pretty cost effective. And so the idea was trying to get that kind of evidence into how government programs function. There are also a couple of, I'm not going to go into these in detail, these are external to government, but they were kind of big voices nudging government. So one was the Coalition for Evidence-Based Policy, which was a nonprofit solely formed to influence Congress and try to get more evidence into legislation. Moneyball for Government was actually taking the idea from Major League Baseball and the movie Moneyball and trying to get members of Congress and some of the political appointees and agencies to see that they could do the same thing in social policy. And then towards the end of the Obama administration, Patty Murray and Paul Ryan had a bipartisan bill that created what was called the Commission of Evidence-Based Policy, which is basically saying, we want to form a commission to tell us how can we get more federal agencies to conduct more research and leverage the data they have already to better be more efficient in what they were doing. And their report came out recently, and just sort of to highlight, I would say there's a lot of summaries that you can get if you want to learn more about this, but they basically came out suggesting that the government needs to create more access for external researchers of their data, but in a secure way that protects privacy. But they also said we have to increase the infrastructure within government of more people who get evidence, because, I mean, as Anne mentioned, I was in an office that was focused on evidence. My job was always trying to get at the table because, to be honest, the leaders of programs or political leadership, they didn't always want to hear that something didn't work. They didn't always want the researcher at the table. And so they are saying that we need to get researchers embedded into more places in government to be at the table. So now we move into the existing administration. So you may know a couple months ago there was a new appropriations bill about 6 months late into the fiscal year, but we got a bill. But it had some hints in there about at least how Congress thinks about evidence, right? So the appropriations bill comes out of Congress. So one thing that was really exciting is that a couple of those tiered evidence programs that we actually were a little concerned were in jeopardy because they were Obama's, and everybody knows that you don't want to continue to study things out of the last administration, but they reauthorized them for 5 years, which is fantastic. So both the teen pregnancy prevention and the home visiting tiered evidence programs were reauthorized. They also created an entirely new program based on this pay for success model. It's actually being implemented out of the Department of Treasury, but it applies to all federal agencies, and it provided $100 million for people to actually invest in these kinds of social impact bonds or pay for success models. And we were shocked to find they also created 2 new tiered evidence programs. They just kind of stuck them in this bill. One of them completely transforms the child welfare system and how you use prevention dollars within child abuse and neglect. And I will show you some examples of what that bill did and why at least I'm a little concerned about it. But it's exciting to see there's so much emphasis on the use of evidence. The second was a reemployment program that went to the Department of Labor. And then finally, it had a piece of the bill that talked about data interoperability, which basically is trying to get data systems to talk to each other and create, code books where we know that that variable over here means the same thing as this variable over there, but across both federal and state administrative data sets. And so it'll be really interesting to see how that rolls out and what that does for the increase of evidence. So now we'll shift from Congress to the current White House. And when I was creating these slides, I had to do an on the one hand, on the other hand, because I will be honest, after doing a synthesis, I have no idea how the administration is coming down on evidence, so it'll be sort of a wait and see. So on the one hand, what's called the A11 guidance, which is the document that goes to all federal agencies to tell them how to create their budget request for the next year, there was evidence all over that. So they talked about developing multi-year learning agendas, embedding research into how agencies do their work. They talked about interagency coordination on evaluation. They talk about administrative data as a strategic asset and how to better use it. And they emphasize the use of evidence to learn and improve, which, as I mentioned, was something that sort of Obama administration kind of brought in. I have my own theories about how this happened. You guys can answer those questions later. On the other hand, we have already seen that the use of evidence has been used in the Trump administration as a punitive tool. So you can see, it was a big press when Meals on Wheels was cut. They said it's because there was no evidence that it worked, which is actually not true. There were actually a number of studies showing Meals on Wheels was effective. Same thing with some of the teen pregnancy prevention programs. They said there's no evidence to show these work. And then they shifted funds to things that we actually have no evidence that they work at all. Shockingly, they canceled that National Registry for Evidence-Based Programs and Practices. No warning, gone. With some post announcement saying, oh yeah, we're going to take care of this function in some other way, because it was required in a bill, but we have not yet seen what's going to happen with that. They do actually mention in the president's proposed budget some words that suggest some evidence support, so pay for success and social impact bonds and rapid cycle evaluation. But in that same document, there's sort of a mixed results. So the first bullet there is talking about what started in the Obama administration as one of the Department of Education's tiered evidence programs, which was called I3 at the time. Now it's called Education, Research, and Innovation. But they were grants that you could apply for: a small grant to develop an idea, a medium-sized grant to sort of test it in multiple locations, and then a large grant to scale something up and test the effectiveness at full states or multi-state level. That actually got a suggested budget increase. Now this is the president's budget, which often does not actually turn into action. It just sort of indicates a level of what his policy priorities are. So that was surprising. And it also talks about using what are called waiver authority for states under our cash assistance or TANF program to actually give states the ability to innovate as long as they then tested them in random assignment designs. So that's pretty good. At the same time, massive cut at the Institute of Education Sciences, which, remember, was started in the Bush administration. So that, cut by hundreds of millions of dollars. And the teen pregnancy prevention is kind of a mixed bag. So they propose to keep the funding for one of the tiered evidence programs called the PrEP program, but completely cut the funding for the teen pregnancy prevention program. And I should say that they just announced the RFP for the teen pregnancy prevention program, and they seem to be funding new grants. So I have no idea what the administration and how they think about evidence. So I'm going to give you kind of an overview then of like, what does this look like in statute? And there's going to be a lot of words on the screen because I excerpt pieces of legislation, but I've underlined and highlighted places to sort of focus, and I'll kind of talk you through why this is important. And as I mentioned, just to think about this, so the law can be more or less prescriptive about what do you mean by evidence, how do you define it, what are the studies that count. It does indicate a level of congressional intent about what they hope this program is going to do and what kind of evidence that Congress thinks is important. But the problem is it's not well aligned across bills. I actually just got a grant from the WT Grant Foundation to actually do a synthesis across these bills to try to then develop some kind of template for Congress to say, if you'd like to do evidence-based policy, here's some language that will get you to your goal, rather than having every single program completely define it differently, which is just causing mayhem. But you'll also see that they kind of evolve over time as I think Congress puts something out and they see what the executive branch does with it and they say, oh no, that's not really what I meant. So then the next time they do an evidence bill, they kind of tweak it. And you can see over time that these kind of evolve. So this is the oldest bill that I'm going to pull out. It doesn't mean it's the oldest that was put out there, but it was a Head Start Act of 2007, and everything that you see underlined are words that have something to do with evidence. So you can see that just in this small section, there's a lot of language in there about rigorous, systematic, objective, and looking at causal relationships and looking at valid measurements. But you can see in the highlighted text that it can get very prescriptive. So a causal relationship only with research designs that eliminate plausible competing explanations for observed results, such as but not limited to random assignment designs. That's pretty prescriptive. It's actually not as prescriptive as some other ones, but it's basically giving you a clear directive of what Congress thinks is valid for evidence. They also have language in there about being accepted by a peer-reviewed journal or critiqued by a panel of independent experts. That one in particular, I will tell you as somebody who's tried to execute these bills, is very problematic, because it means that we lose all of the government research, which sometimes is actually extremely high quality. It also means that we can't innovate as fast as we want to, because it takes 18 to 24 months for your paper to get through a peer-reviewed cycle at the minimum. So we're going to always be a few years behind. And then this consistency of findings across multiple studies is great in abstract, but we often don't have multiple studies on most things, and so how do we actually comply with that? The Maternal, Infant, and Early Childhood Home Visiting Program, this is their statute, and you can see there are some squishy terms in here that are highlighted in yellow. So research-based, what does that mean? Sustained, how do you want to define sustained? Post-program implementation, post-program exit, 6 months, 1 year, 3 years, totally up for you to decide. And well-designed and rigorous, like what does that mean? So as somebody that had to design the systematic review, I had to take all of those things and decide what I thought that was going to get us to balance what was the most rigorous thing we could do, recognizing where the field was, which was actually very, very hard. The Families First Act. So this is the one that I mentioned was sort of stuck into the most recent appropriations bill, transforming child welfare services. And the challenge that I find is that the bar they have set now, because I have a feeling Congress is saying, you guys are just still not rigorous enough, is so high that I'm not sure what's going to qualify. So this is the promising approaches bucket. So this is the lowest tiered, still requires a comparison group. And if you know much about prevention of child welfare and the kinds of programs that might meet that bar, what we're doing automatically is constraining the number of models that states have to choose from right away. And it cuts out anything that's in the development phase or, sort of conceptualization phase, and how long is it going to take for them to meet that bar. So this is going to change the way we do child welfare services with those lines. This is the next bucket. So even more language you can see in here, but it's already requiring a random assignment design or a rigorous quasi-experimental design carried out in usual practice, which is almost never the case, right? So we're already further in constricting. And then sustained effect. You remember in the McVie, it just said sustained effect. I could then define that however I wanted to, which we ended up defining as 1 year post-program implementation. They decided they probably didn't like the way we did that, so now they've told us that a sustained effect is at least 6 months beyond the end of the treatment. So I have a question, right? How do we know treatment ended? How many families drop out? What kind of, how much is that going to bias the kind of conclusion we can draw? So this statutory language ends up driving so much. And my worry is a little that we have people like 22-year-olds, no offense to any 22-year-olds in the room, but writing these bills that can completely transform the field. I'm not going to go into this, but you can see that in the third bucket, it gets even worse. So then we have all these statutes. How does a bill become policy? What are the options for the executive branch? So I'm going to give examples for each of these, but they have a few options. So one is regulation, which is an option that allows you to be a little bit more codified because it takes so long to get regulations approved. It could take a year or longer. A funding opportunity announcement, which is just basically in order to get these funds, this is what you need to do, which allows you to be a little more pivoting and nimble, but it means that somebody could come in the next time and change it up. There are the systematic reviews, and sort of what gets put on these lists dramatically changes sometimes what people are paying attention to. And then policy guidance, which is the squishiest, which is basically a memo, a dear colleague letter, whatever the agency uses, that says, we would really like you to do this, but there are no carrots or sticks attached. And as I mentioned, sort of that translation of that statutory language into any of these options kind of depends on how much flexibility that the staff are given. And what that means also for the allowance of funds. So sometimes the statute says you must have, 3% of these funds must go to research that would continue to build the evidence base. Other times it actually says you may not use these funds to continue to do research, and then you're sort of stuck with whatever level of evidence you have. So for example, the Head Start Act of 2007, 10 years to get regulations based on that bill, 2017. But the bill required the use of research-based curriculum, but that was all they said in the bill. So then these regulations went through and sort of defined that for Head Start programs, and actually along with that, their technical assistance centers are putting out lists of what meets these criteria. But so they in the thing that's the hardest to change, they put out a definition, but they're using their TA centers to sort of allow them to be flexible and change what programs meet that bar. You'll also see I underlined to the extent practicable, which is a government way of giving flexibility. So in the maternal, infant, and early childhood program, it has for the tribes to the extent practicable, because there just really wasn't the evidence base in tribal communities. And what was nice about that is that it allowed us to say, this is what's practicable. And gave us that flexibility. Unfortunately, in that program, they did not give the same language to territories, which were in the exact same position. So the territories have to meet this high bar that the states met, whereas the tribes actually got that level of flexibility. But you can see in the regulations, you can do the same thing. I'm not going to go through this, but the Department of Education used regulations to define what kind of evidence that their grants will create. So they have this thing called the Edgar rules for their grants, but they lay out exactly what they mean by a high quality impact study. And they give standards on exactly what it has to meet. And so you know that in order to get a Department of Education grant, you go to their regulations and they will tell you exactly the kind of study design that they're looking for. The systematic reviews, as I mentioned, they can have a big carrot and stick. I think, there are certainly challenges and opportunities in sort of highlighting some of these programs, but they are completely hamstrung by the available evidence in the field. They're also very expensive to do well. And so I think they're a really nice lever, but there are certainly some challenges. I'm not going to go into all the detail on them, but they have been critiqued. So one issue is that every systematic review is a special snowflake. So they often have a very specific set of outcomes that they're looking for, or a specific statute that's saying, like, you must use a random assignment design. And so what happens because in a lot of behavioral and social services research, right, they're crossing lots of different government agencies. So Nurse-Family Partnership, which is a home visiting program, has been reviewed by the SAMHSA systematic review, is reviewed by our systematic review, is reviewed by the Department of Justice's systematic review. But like Justice only looked at justice outcomes. SAMHSA only looked at mental health and substance abuse outcomes, and we looked at all of them. So NFP gets a different rating on each systematic review. And what I can completely understand is the states say, what am I supposed to do with that? Right? You're telling me this is supposed to help me use evidence, but now you're contradicting yourself across the government. So I'm not sure how to resolve that problem, but that's definitely a problem. What you count as meeting the evidence bar varies across systematic reviews. Some of them use statistical significance, some of them use effect sizes, and some of them use clinical significance. So at least with the teen pregnancy prevention evidence review, we got a critique by one of those external groups that most of the programs only changed attitudes and knowledge and did not actually change teen pregnancy rates, and therefore we were not actually driving the evidence bar. Of course, what we had though, and they were saying that was because teen pregnancy rates are the most clinically meaningful and policy meaningful. Of course, the problem is that most studies don't follow kids long enough to actually get teen pregnancy rates, especially for a program starting when they're 12 or 14. And so they're trying to figure out that tension of like, what do you count as evidence and sort of beating that evidence bar. As I mentioned already, which outcomes matter to you and what you look at drives the decisions that you make. And then there are lots of kind of more squishy topics that we don't have good answers for. So in the systematic review I ran, we got public comment. And one of the things they said is you must include the independence of the evaluator. But what does that mean? Like, does that mean that the model developer wasn't running the clinical trial? Does that mean that the model didn't pay for somebody else to run the clinical trial, which means they could change the findings if they wanted? Does that, what does independence of the evaluator mean? And for these high stakes systematic reviews, you have to be able to defend whatever decision you make. So in ours, we decided to just report things like that, but we didn't actually include them in the criteria of what got funded or not. And people can critique or not that decision. Funding opportunity announcements have lots of different levers that they include. And so they might have a certain percentage of the money has to go to evidence-based programs. One thing that I've seen that I think is really creative is what I call entry and exit in evidence. So they might say, in order to get our grant, so this is where the Department of Ed I3 or EIR grants are. In order to get our grant, you have to have a certain level of evidence to get that grant. But you also must do some kind of impact study while you have the grant, and we want your exit evidence coming out of that grant to be at this other level. So they're actually pushing people down that sort of continuum of evidence. Then there's also sort of programs that are deemed demonstration or sort of innovative programs. So we don't actually know a lot about fatherhood programs and the impact of fatherhood programs, but because the law called it a demonstration program, we were able to actually continue to do research and try to build the evidence base. So try to get to the point where in case Congress said, like that child welfare bill, in case Congress said to us, you can only fund evidence-based programs, we were ready for it. So I'm gonna finish with opportunities and challenges, and there's a number of them, and again I'll just touch on them briefly, but I'm happy to answer questions about them. So as far as opportunities, it is better than the alternative, right? We were funding a lot of stuff that we had no idea whether it worked or not. And I think that's really great. It does increase the chances that some of these federal and state investments will drive outcomes. And I truly believe the more we look at data, the better opportunities we're going to have to improve outcomes for the people we're trying to serve. It was an interesting side effect that it also dramatically increased research practice partnerships, because these states would say, you're asking me to build evidence on what I'm doing, but I don't have the internal capacity to do that. And so they needed to reach out and build these partnerships. In the federal side, as I mentioned, my job in part was to being like, hey, let us in the room, have us at the table, have us help you with that, But after these passed, we were always at the table because they had to. The law said that the evidence had to rule, and so they needed the scientists at the table. It dramatically increased the amount of money for research, which is, of course, really exciting for us. It also increased the communication between the funder, the model developer, and the implementing agency. So, for example, in the city of New York, they decided to do evidence-based child welfare services. And what they found was the requirements of the city of New York had for their child welfare services didn't align with what the developers of these evidence-based programs needed. And the funder had their own requirements. And so they had to say, okay, everybody get in a room and figure out how are these local child welfare agencies going to actually do this and do it well, which I think was the first time that these entities really started talking to each other. And then I do think that there's great opportunity in these integrated data systems and what we can learn. Obviously, for now, we're going to have the data that we have, which isn't always perfect if you know much about administrative data systems. But the more states and counties start using the data, the more they're going to ask for different data. And my hope is over time, those data systems are going to start to improve. There are many challenges, though. I think, as I mentioned, this mandated use of research and evidence is great to some extent, but it doesn't always take into account sort of where the state of the field is and what that might do to change. There's sort of those unintended consequences to change what that field is doing. And I think people haven't been as thoughtful, at least from the congressional side, about what that means. And sometimes it's also mandating research design. So what we saw was a lot of places going right to a random assignment design because that's what the law wanted, when that program wasn't ready for a random assignment design. And so you end up concluding that it doesn't work when it was really that they needed to do a lot more development work at the front end to get to that point. But because of these pushes, they just sort of jumped right to the end. I am particularly concerned about this overpromising, because I think we are selling this as evidence-based policy is going to save the world. And what happens if it doesn't, right? We have a lot of evaluations going on out there that are now getting in the hands of policymakers. And they're going to start concluding, as we know, that there is mixed evidence. And potentially, if it's anything like the medical field or even private sector industry research, they find that less than 10% of things actually are found to be evidence-based when replicated. So we're going to find the same in social programs. The risk with social programs, though, is that people can find that as a reason to cut them. You're not going to say you're not going to ever get treatment for a disease anymore, but you could say you're not going to get prevention services. And so that's my strongest worry. I do think that people say we're not using evidence in policymaking, but we're underselling what kind of evidence is getting used. So I mentioned at the beginning, we're really focusing on these things where we can point to it and say that statement or that evidence drove that outcome. But I think the more powerful way that evidence is getting used is something called conceptual use, which is where it changes the conversation. So as a researcher, you're talking to a policymaker and you tell them that we have decades of research about juvenile justice and how they interact with the system. And that changes the way they think about juvenile justice reform. And that, to me, has longer implications than testing the random assignment of one particular intervention and program in one particular point in time. So we need to do a lot more about studying how do we actually increase that conceptual use. I am worried about the evidence as a weapon because obviously the more it gets used as a weapon, the less people want to actually do high quality designs because they're worried, right? They're worried their program's going to get cut if they find it doesn't work. And then I think the transparency and reproducibility conversation that's happening right now in our field is, I love it and it's great, and I'm working with some folks on that, but it equally could be used as a weapon. The EPA just announced that the only kind of evidence that they will use in regulation right now are studies in which all of the data has been archived and available for public use, which means that all the seminal studies from the 70s and 80s citing like that, pollution affects health are not included and potentially can't be because the informed consent didn't allow those data to be publicly archived. So I think we have to actually be very careful about how we want to look inward and certainly improve practice, but what are the unintended consequences when it gets involved in policy making? And then I have 2 more slides. So I think we do need more evidence that can be produced more quickly. There is certainly a push in the policy world to move away from large-scale random assignment designs and more rapid cycle designs, because we need this evidence to come out to influence these conversations at a faster pace than a 5 to 10 year long RCT can give us. We need more replication work, and I think NIH is clearly aware of this, and that replication studies often don't get rated as highly, but obviously we need to know, is it going to work not just in this tiny rural area in Kansas, but is it going to work in Chicago as well? And we don't have as much of that. We also don't have as much external validity information reported in articles. We don't know how far can we really generalize these findings. And that's really hamstringing those who are going to pick a program to know what program that they should pick. And a little plug for the work that I do with Anne and Cynthia. We also don't have a lot of empirical support for active ingredients. So what happens a lot of times with these programs is that they throw everything in the kitchen sink at a family, and something in there is causing that impact, but we actually don't know what. And it could be that it's only 2 of 15 things. So we need to actually build the evidence base around that, because otherwise we're going to scale with things that are far more expensive and complicated than they need to be. And we could be spending a lot of time sort of focusing on things that aren't driving impacts, which runs the risk of that we're not going to find it works at scale. And then just sort of things like when we're going out, this gets to these like adaptations, right? Adaptations are going to happen. We don't know a lot about how to have that conversation about how to make an appropriate adaptation, going back to sort of that lack of empirical evidence. We don't know how effects vary by subgroups. Often it's post hoc, but even then it's really rough cut subgroups. Like maybe we have specific race ethnicity categories, but we don't know exactly why are things varying and what does that mean for rolling things out. And we also still need to learn a lot about the infrastructure around these programs that require them to be done with quality. It's one thing to say it had impacts in a clinical trial, but in the field, what do you need to do to actually make those reach the same impacts? So I guess some of my reflections on next steps, I'm personally very aware of the sort of the Goldilocks of like, I don't want to oversell and underpromise evidence-based policy. We can't go out sort of selling it without cautions, but we also can't be so overly cautious, because sometimes academic research may be like, well, we don't want to do it in that circumstance, in this case, and policymakers just stop listening. So we have to find out how to talk about this in sort of that middle ground, so that we can keep this movement going, but with a realism. I think we need to design our programs for scaling in mind. Most of them have not been, and so a lot of this evidence that I mentioned is lacking is because we didn't actually ask those questions at the start. And conducting more research with this sort of precision lens to sort of unpack what are the active ingredients, how do we make these programs more efficient and effective, researching when they go to scale. I'm actually, as part of the Society for Prevention Research, I'm in one of their methods for advancing prevention science, which we're focused on what would it take to scale up prevention programs at a state or national level. And what we have found is there's almost no research on that. There's theory, but there's almost no research. So how do we study that? And then the final point that I'll make is we need a marketing and distribution system for evidence-based programs. So in the automobile world, the person who developed that automobile is not the same person who sells it, provides technical customer support after that, sort of builds the actual car. But that's exactly what we're asking evidence-based model developers to do. They go out there and they have to then fund a nonprofit, and they have to then, build business, and they have to support and provide training and accreditation of sites and all this stuff. But most of the time, that's not where their skill set is. So how do we build a system that will actually support them to get this stuff out in a more efficient way? And I will end with my favorite sign from one of the protests. This actually was out of the Obama administration. So what do we want? Evidence-based change. When do we want it? After peer review. So I'm happy to take questions. Yeah.
Well, your passion is certainly contagious. So
Good.
I know that. The issue is the application of evidence-based practice can be distorted by financial considerations and cost effectiveness. So when you have breast and prostate screening, you also have strong provider bias in terms of implementation, in terms of the cost involved. In the WIC program, which I was involved with, we anticipated this by having nutrition screening as a critical element of it so that we could give expression to issues of evidence. But in its application, it frequently can become distorted in terms of how it's used, either positively or negatively. So I wonder if you would talk a bit about the financial implications of some of these decisions, both pro and con implementation and its impact, as well as its use once the evidence is accepted and implemented in terms of actually both reinforcing or limiting the embrace or implementation.
Yeah, so one thing I didn't touch on is sort of return on investment and benefit cost analyses. They certainly have been part of this conversation. I have a few thoughts on them. I think the ones we at least do have, and especially, and I should say, like, I'm in the social policy, realm, so I know those the best. They have been done often with these same sort of hothouse clinical trials, which are not in the real world. We don't actually know a lot about what it actually costs to do these things in practice, in like a statewide. So the return on investment you get is often with a higher effect size because it was usually the developer running that trial, and it may not be realistic costs, but those are certainly the return on investment ratios are being used to sell these programs. Some of the required evaluations, like the one that Anne's working on, has a benefit cost analysis as one of the required elements. And I think because of those two variables that I just mentioned, it's part of my caution and my worry that when the report comes out, if we find that it's not cost beneficial, is that going to be somebody points to it and says, look, see, evidence-based programs are not beneficial. They're not providing that return on investment that we hoped. And so I think when I left government, they were having a lot of conversations about how to talk about that in this, it's very nuanced with a policymaker who doesn't want gray and nuance. And I'm sure you guys are having those conversations right now. So I think that's one worry of mine. The second piece of it is that the cost also is a driver of what programs people pick. So I know the home visiting world the best, but the cost per family, and these is an average cost, and I think it masks a lot of stuff that's happening behind the scenes, anywhere from $400 to a family to $12,000 a family. And so when a state is looking at what do I invest in, one of the factors they might be looking at is, okay, the evidence base on the $12,000 family is greater, but I can serve more families with the $400 family model. So why wouldn't I just pick that one? And it may not align with the outcomes they're trying to change and all of these other factors. But I was certainly part of some conversations where people in government says, well, how do we get that $12,000 model cheaper? And can we just tell them to just reduce their costs? But my response to that was, we don't have that empirical evidence on active ingredients to know if you cut that thing, because that was the most expensive, if you just cut the thing that's driving impacts. So I don't have a specific answer other than to say it's a very complicated factor. Yeah.
A couple of observations and a couple of related questions. My understanding is that the whole construct of evidence-based grew out of medicine.
Yes.
And it grew out of the problem that a lot of physicians were doing things based on personal belief and personal bias. Tonsillectomies is a classic example, but there are many classic examples. And so much more controlled studies were done. And then it expanded into drug studies. The problem that I see is expanding this into social science and behavioral science, because I don't know that there is an equivalency. Question number one, is evidence-based programming way overrated? Second, is that a lot of evaluation research is short-term evaluation research. Let me give you one example, of which there are many. MTO, Moving to Opportunities, one of the classic housing studies in the United States. The evaluation that was done shortly after MTO showed marginal positive impacts. And it was left at that, and MTO was left to go into the dustbin of history with a lot of other programs. But the evidence on a 10-year follow-up study on MTO said, you know what? That's what was wrong. In fact, the impacts on maternal mental health were profound. And those in turn led to a whole different trajectory for a generation of kids. But we don't do that. So our quote evidence-based programming evaluations are short-term, and we draw conclusions that in fact either are wrong or counterproductive. Thoughts?
Sure, yes. I have a few different sets of thoughts. I think the example you gave about MTO is also an example of how policy is not rational. So there was a program that we studied called Building Nebraska Families. That was a home visiting program to reach families that had low rates of employment, to try to help them get them support to be able to then go out and get employment. We found it was wildly successful, one of the largest effect size we ever found. But by the time we got that effect, the governor had changed and they canceled the program, and it's never come back again. So even if we had all that evidence, the mixture of politics and timeline are certainly part of these discussions. And I think some of this imposed use of evidence is trying to actually force that more into the policy realm, to say we're going to take the politics piece out to some degree and try to get that focus more on the evidence piece. As far as the long-term findings, I think the answer is it depends. So it depends on what area you're talking about. I mean, within the home visiting world, we have some of our random assignment designs now have impacts 20 years post program. Of course, they're still in the original clinical study, which the generalizability of that, we don't know. Whereas other programs, like I mentioned, sort of the fatherhood programs, we have very few programs that even meet the evidence bar at this point, let alone long-term findings. And that's what makes some of this so complicated, because you can't impose the same requirements on every field, because the amount of evidence available and the rigor of that evidence varies so dramatically. And actually, depending on what you put in place, actually could drive how a program, rolls out for years to come. And then whether social policy has that level of evidence, I do think that this, as I mentioned, sort of, education world 10 years ago didn't have this level of impact evidence. I think it is transformed in the last 10 years, and we have a lot more impact evidence, and the same thing is happening in a lot of these social science programs. But we're sort of at the toddler stage, in that there isn't a lot of replication, there isn't a lot of multi-site trials necessarily in some of these programs to know whether those initial impact studies are going to carry us forward. So I think we're just kind of in this space where I don't think it means you throw it out. I do think we need to keep moving that down the road, but we need to do it in this way that we don't oversell and underpromise. Yeah.
Thank you for stimulating presentation. But I have kind of a sense that it's a parallel universe you're talking about. You don't have to think very long. There's a very long list of recent decisions by senior policymakers in the government that are made unencumbered by any thought about evidence. whether the evidence doesn't exist or whether it does exist, it's ignored. And that's not new. I think it's more pervasive, not much more pervasive under this administration. But as a former policymaker who made a few decisions myself with really not very much evidence. So I'd like for you to just talk about that, but also something that is, in its intensity, I think unparalleled, is the attack on science. And it's not just from the Trump administration. It's gotten to the mainstream. And what are your views about how that can be counteracted?
Yeah. So your first question, I think it's certainly, we'll have to watch and see. I'm originally from New Jersey, so I'm originally more pessimistic maybe than optimistic, but I have a little more optimism, and in part it's because of that long history that I put up there of this starting in the Bush administration, because a lot of federal employees have only worked either in the Bush or Obama administration, and they're the future leaders, and they came in with this idea that evidence is important and should be part of your conversation. And I think once they have transformed the way they're thinking about it, it's going to be hard to shift them away from that. And that's what I mentioned, that why did the White House budget guidance look so different? I actually worked at the White House for a little while, and I'll tell you it's because the civil servants there still believe in this so much that they got that through, whether their leadership told them to or not. So it means that maybe the senior leadership isn't aligned with the career staff, but the career staff are going to be there a lot longer. And I think we've seen the same change in how states and counties also think about evidence. So I'm optimistic, but I think cautious about sort of how much this current administration might shift us away from that. But to the second point about the attack on science, that's a little bit of what I was referencing in the transparency and reproducibility critique of the field, and my concern about how we talk about these things can dramatically influence how those conversations go forward. And I don't have an answer about how we are self-aware and self-critical to continue to improve our science without making other people think, well, science doesn't know what they're doing, or they have mixed findings, and so we just throw it out. I think the main thing that I would gravitate to, and it's just my personal thought on the spot, is doing a lot better around science communication. I know, so there's a number of reasons why I went to Child Trends as a particular entity, but one of the reasons that I went there is that they have a national reputation of taking science and explaining it in ways that policymakers can understand. And if you go to a conference, a policymaker is like, oh, Child Trends, I get your newsletter, I totally follow it. But we need to do a better job of how to explain complex, nuanced things to a range of audiences so that they aren't scared away, they aren't, sort of lost in all of the jargon. But it is certainly a unique skill set that many people don't have, and we have to go through. April works with me. We just went through a training of how do you explain moderation to a non-science audience. That's my only thought right now, but there might be other ways that that we could try to address that problem.
I think we're at time. Yes, probably people outside the door. Lauren, thank you so much.
You're welcome.
So much smarter.